who look at that. And we'll be working going forward on an item analysis to kind of take a look at actually how test questions are marrying up to that referenceable material. We were advised by staff that a company called ProExam bought out a company called PSI. Those are the companies that had been working on developing our New York State written exams at all levels. And Mr. Johnson will be working with the company going forward to develop exams with the new company. We learned some facts about the pass rates for 2016. And we learned that there were 3,322 CFRs certified with a 91% pass rate, 10,780 EMTBs with an 87% pass rate, 80 AEMTs with an 89% pass rate, 269 EMTCCs with an 87% pass rate, and 1,440 paramedics with an 86% pass rate. And those numbers seem to be fairly consistent with historical on pass rates for those sitting for the New York State exam. Core sponsors should be made aware through their regional reps, if they don't already know, that there will be no more testing of Station 5, that is the long backboard station. Instructors will still be required to teach that, as immobilization of the spinally injured patient has not changed. Only the decision-making for which patients do get immobilized has changed. So therefore, the skill has not changed. However, it will be taught but not tested. The PSE manual has been updated and the old curricula taken off the website. We were made aware to pass along that with regard to instructor updates happening in some of the regions across the state, some areas seem to be restricting attendees to only the core sponsorship associated with that core sponsorship giving the instructor update, and we're reminded to pass along that instructor updates are regional endeavors and must be available to all instructors in a particular region, regardless of where they may work. Under new business, we are expecting an annual protocol update to occur, hopefully in the late spring. It will be done through the Moodle teaching platform, as we saw with spinal immobilization and hemorrhage control. And from an educational standpoint, that certainly is a very, very reliable and very intuitive, easy to navigate platform to get a uniform educational process out through the entire state of New York almost instantaneously. EMSC is going to be reviewing all pediatric protocols with a focus on safety and a focus on ensuring that we have the appropriate training, the appropriate practical skills exam, and the appropriate approach to treating our pediatric patients. And then our last bit of information to share is some old or still outstanding business. As many know, there is an active EMT critical care tag that has done a significant amount of work over the last several months, collecting a significant amount of data. And this is really taking a look at the implications and the impact of EMT critical care technicians on our EMS system here in the state of New York. This is a complicated and a long-term process, and the tag is actually planning on issuing a full report to all concerned at the May meeting. This effort is being done with full transparency, and to that end, I'm going to relinquish the microphone to Dr. McAvoy, who will read a statement into the record. That same statement was read into the record yesterday at CMAC as well, and we want everybody to be on the same page with the information that's being disseminated. So with that, Dr. McAvoy.
This is just a preliminary report from the critical care tag. The CC tag was tasked with evaluating the future of the critical care level in New York State. And years ago, you may remember when CMAC and SEMSCO reviewed the revised National EMS Scope of Practice document, CMAC voted to continue the CC level of care in New York State. And since that time, several issues have arisen. These include New York State now being the only state with a CC level of care, which eliminates portability in disasters and causes some reciprocity issues. There's a push from the governor to bring New York into compliance with nationally adopted standards when those exist. The portability of certification between states is increasingly becoming a problem. And there's an inability to update the CC training curriculum and exams right now due to the costs, the administrative burden, and the lack of really any national equivalent. So therefore, there's been some recent discussion about sunsetting the CC level in New York State. So the TAG is currently exploring a number of things, as Bob alluded to. Amongst those, the CC use in each region, the current CC curriculum, the ability to sustain the CC educational updates. We're looking at original course participation trended over many, many years to the present. We're looking at refresher course numbers, the use of CME refreshers, and other training, exam development, and maintenance issues. The TAG is also evaluating how a phase-out of the CC level or a continuation of the CC level might affect the state, including issues such as barriers to upgrading current CC providers to the paramedic level, the establishment of streamlined bridge courses that would optimize the costs and time commitment of CC providers, enhancements perhaps to the AEMT skill set that might facilitate transition of some CC level agencies to AEMT, and the timelines with which a transition to either commit to maintaining the CC level or a transition to sunsetting the CC level would be feasible so that we can assure continuity of care to all New Yorkers. So the plan is, with this voluminous data, to present a full report to this body, to Training and Ed, and to the other committees at the May meeting. So if anyone needs a copy of this statement to bring back to your regions, I've emailed it to a bunch of people. I'd be happy to send it to you also. Thank you.
Thanks, and that concludes the Education and Training Committee report, Mr. Chair.
Thank you very much, and thank you for the comprehensive but specific update on the CC. Next we have the Finance Committee. Patty?
Where did he go again? Oh, he's over there. Can you put our, thank you. Realities, please. Thank you, Mr. Chairman. So the committee has met a couple times on the phone and also yesterday, and we do have a seconded motion to come before this body. So the first thing we want to just show you is what we're currently living in this current fiscal year, which will be ending soon. Our budget for the Bureau is a little over $19 million or $19 million and a half, of which only $16 million they can actually spend. And if you need more information on that, I'll defer to Tom to tell you about that part. Of that $16 million, it's broken into two categories: aid to localities, which is funding the program agencies, the SEMSCOs, and the training reimbursement, of which in the training reimbursement, 50% needs to go to that category. State operations is everything else, or what Lee calls the other side or something like that. That is the Bureau staff, miscellaneous contracts, and so on. So again, currently our current budget is $16 million. As you are very well aware of, that keeps declining. When the cost of living keeps increasing, our budget certainly hasn't kept up with that. So in fact, we're seeing a decrease. The program agencies are certainly aware of the fact that they haven't seen an increase since 1997. Minimum wage will certainly impact the localities. With the increase in minimum wage for the supportive staffs like victims, auxiliary, for practicals, and so on and so forth. This part's, I've been trying not to put my attitude into a lot of this, but as we all know, there is quite a crisis in Essex County, in the state. I think we're all feeling that. And Lee just mentioned to us that there are no planned initiatives. That's partly because they're not fully funded, fully staffed. They are currently experiencing a 20% amount of people not staffed, so they still have 8 positions that could be filled. That certainly could be a help to the rest of us. Training reimbursements to the sponsors and the agencies is insufficient. We all know that doesn't cover the cost of us doing business at the localities. So with that being said, if you can go to the next page, Donna. Next document, I'm sorry. So this appendix is part of a document we've put, actually, collaboratively, we put this together, and it goes into detail and explains the backup to these numbers that we're giving you here. So aid to localities, you can see our amounts that we're budgeting for, which comes to a total of $16,295,127. The state operational side, we have budgeted $7,885,000 for our total budget of $24,180,127. This increase covers a 10% increase to the program agencies and SEMSCO contracts, increases funding the staff, the Bureau, to the full staffing levels that they should be at, provides funding to increase training reimbursements at the local level. And again, the training reimbursement is at least 50% as dictated by Article 30. That was a seconded motion from the Finance Committee.
Thank you. Are there any questions for the chair of the Finance Committee? Okay.
Article 30, it's not Article 30, it's 97Q of finance.
So being corrected, 97Q of the Finance Law.
Well, so a lot of work has gone into preparing this year's budget by the Finance Committee, so thank you. This comes forward as a seconded motion, so if there's no other discussion, if we can, all those in favor say aye. Aye. Opposed? Abstentions?
Point of order, I think it's in law that we have to provide this information to the legislature. It might need to be a roll call vote because it is in law.
Okay, well, then in that case, I thank my esteemed colleague and deputy parliamentarian, since our usual parliamentarian is overseas this week. And Donna, if you would call the roll.
Dr. Alexandro? Yes. Patty Bashaw?
Yes.
Allison Burke?
Yes.
Steve Caddy?
Yes.
Warren Darby?
Yes.
Jim Devers?
Yes.
Robert DeLoggy?
Yes.
Sarah Duvall? Yes. Lester Fremantle?
Yes.
John Hassett?
Yes.
Ronald Hassan?
Yes.
Steve Kroll?
Yes.
William Little?
Yes.
Kim Lippis? Michael Mastriani?
Yes.
Michael Murphy?
Yes.
Thomas Pasquarelli?
Yes.
Mark Philippi?
Yes.
Michael Reed?
Yes.
Raymond Sarowick?
Yes.
Roll call complete.
Thank you. Well, let's hope that our members of the state legislature, when this report is sent to them, read the fine print in detail and notice the differences in this budget, and hopefully in the budget session are able to use that information to advance EMS.
I just have a quick question. Does this go unchanged to the legislature, or does somebody above you look at it and modify it?
The way that the law is written, it goes to the commissioner, the governor, and the state legislature. I provide it to our Office of Governmental Affairs, so I don't know that they change it. Historically, they have not.
So who at the legislature receives it?
I don't know.
All right. Because I happen to have a senator that is the head of the Senate Finance Committee, so I will make some inquiries when the time comes to see if they see it.
Can I just make a comment, Mr. Chairman? So I think I'm optimistic, Lee's not so much, but I think we need to start and then this is probably not great terminology, remember I'm coming from the North Country, poking the bear a little bit. We really need to start advocating for ourselves, and I've said this many times to Steve, but we're not even on the radar, and we really need to start getting ourselves out there, and otherwise this is not going to get better, this is going to continue to get worse. So I would take it back to your local legislators. I know our county has a legislative committee at the board level, and I think we should be talking to our Senate and Assembly.
Patty, are copies of this available to the members of SEMSCO so that they can take it to visit their local legislators?
We'll get it to Donna, and we'll make sure we get it out.
Okay, thank you. All right, next is EMS systems.
Good afternoon.
And Ron is subbing for Dr. Langsam, who is
Who will not be
excused from this
forgiven
meeting.
by Ron for being out of the country.
Rod has tried to retire before. but-
Yes. Well, good afternoon. We have no seconded motions that come forward from the committee. We start out with a staff report. Apparently there's going to be a DOH infectious disease exercise coming up the last week of February and in the first few days of March. And this will be primarily for hospitals and for long-term care facilities. EMS will not be involved directly as far as boots on the ground or anything like that, but it will involve testing and utilizing communication systems to get the word out. So they are going to be sending notification to county EMS coordinators in about a week or so that this exercise will take place, and they'll be, again, testing communications, in a way testing the EMS mobilization plan, checking contact information to make sure it's accurate. If the primary person's not there, can they get hold of a secondary person? Is that accurate information, et cetera? So that'll be coming up last week of February, first few days of March. We did talk about the change in the epinephrine auto-injector law. So Lee covered that, so I'm not going to go through that again. In the regular staff report, we currently, which is important for us, we have 2 appeals that are currently in front of the Bureau of Adjudication. Now they're down staff as well, from what we understand. I know we had one of the cases was actually in the hands of an ALJ, and then he retired mid-review and had to be reassigned. So we have 2 issues up there. They're down at least 4 administrative law judges in their bureau. So we don't know when they're going to be coming. But we have 2 that we will eventually have to deal with, at least. They've seen a large increase in the number of municipal CON declarations, so that's happening. I remember years ago we would get probably 2 or 3, or the Bureau would get 2 or 3 different CON-related issues coming from the REMSCOs. In the past quarter, last quarter of 2016, in essence, they had 50. And we received a report on many of those. That's a lot of work to be done. A lot of those CON issues also require fitness and competency checks, which take some time to do in many cases. Regions are reminded that if they're aware of any BLSFR agencies, basic life support first response agencies that have agency codes, that they need to be active in their communities, responding to, in essence, 911 type calls. They cannot be solely for a factory or something like that. So they need to be active in the communities in order to qualify for funding, or they could have their agency code taken away. There was a question that came up in a lot of the CON-related issues that have happened are transfers of operating authority. And the issue came up about geography. In many cases, on a certificate, you'll have X amount of geography. I know in our own certificates we have 3 counties, but I don't operate in the furthest county away, but I have a CON for it. Well, the issue came up if you're doing a transfer of operating authority and somebody else is, in essence, purchasing that certificate, and the original owner has not been operating in the further away territory, let's say, can that really be transferred and still have that further away territory go to the new owner? And the answer is yes. If it's on the certificate, that's a geography that was initially approved. There was initial need approved at some point in time. Whether or not you're operating there does not matter at the time of transfer. And there is no obligation to totally service every municipality or geography or intersection within your stated geography on your ambulance certificate. We also had the same report about the controlled substances, the 54, now 53 left, and the letter that's coming out, so I won't go through that. All right, then on the agenda was to talk about our transfer of operating draft. As you know, we had a CON tag. It's been going on for about 2 years. We broke into 2 groups initially. One was process, one was need. We had reports back from both. We got together, decided that our definition of need was probably the best that we could find anywhere in the country. So we left that alone. Then we started working more on process and trying to streamline it. And the goal for that was to give better direction to the regional councils, because of all the appeals that we get, they're usually procedural issues. They've messed up somewhere. So the goal of the committee back then, or the TAG, was to look at the different types of CON issues that we have: transfers, municipals, conversions, new entities, et cetera, and have our own checklist, if you will, for each level. The problem is that apparently now that's going to be too onerous, that's too big. Historically, we've used policy statements and CMAC advisories to tell folks what they have to do. The problem was it wasn't really backed up by what was in regulation. For example, when we told them they had to have AEDs and EpiPens, there was no requirement in Part 800 to have AEDs or EpiPens. But the nice folks that we are in EMS, we just kind of follow along and eventually got up to snuff, if you will. But basically, to tell somebody they have to do something in a policy statement that's not backed up in a regulation is unenforceable. So to tell regional councils what they have to do in a policy statement for CONs that's not spelled out in regulation becomes unenforceable. So we are no longer in a position to outline what anybody has to do step by step unless it's backed up by something that's in regulation. So, and on top of that, the new DOH, not new, but the current DOH administration, well above Lee's level, will no longer approve documents or policies that are forcing anybody to do anything unless it's in regulation. So the bottom line is we're not going to go through our transfer of operating authority process as the first step of several. The Bureau is going to take it on themselves to look at 0606, which currently remains in effect. It's still there, okay? That's not changing at this point, but it will change. There will be some other policy statement coming out from the Bureau, but it will not be anything similar to the current 0606, because again, administratively, we're not in a position to tell folks what they have to do unless it's something in regulation. On top of that, as part of our review in the process group, we realized that there were several things that are listed in Article 30 that say the SEMSCO will develop regulations to handle, and we've never done that. And we're going back to some that are 1975, perhaps. And I do know at one point in time in my previous life as chair of this committee, 3 terms ago or more, something like that, we had the big regulatory freeze. And we couldn't do anything like that. And I think we just got complacent and never bothered to look at what was in Article 30 that we're supposed to write regulations for, because that's what we are. We're a regulation writing body along with the department. So the bottom line is what we're going to do is I'm going to send an email to Dr. Langsam highlighting what happened at our committee meeting, that we can't proceed with the current process that we wanted. We're going to the tag will still remain alive for the moment. I will recommend that. We will look again at the process-related things, especially the things that are listed in Article 30 that we don't currently have regulation for, and we'll send that back out to the key members of the TAG and go forward from there. I guess the goal is to give some advisement to the department on what we think is important for putting into whatever policy that may eventually come. But I think the department also wants us to make sure that we actually take a good attempt at redefining what need is, because even though it was a definition that was written in the late 80s, early 90s, somewhere in there, it really isn't germane today. So we're going to take another stab at, I'm going to suggest to Dr. Langsam that we take another stab at that to help the department out. Because again, it was very succinctly pointed out that definitions of need, even though it might apply maybe out in my southwestern region, totally makes no sense in Nancy's region in New York City. So that's where we're at that point. So a lot of work was done, but it's basically at a point where administration would not let something so massive get produced in a policy statement. Any further comments, Lee?
Yeah, I mean, just to clarify, if part of the discussion this morning was 0606 and its predecessor was 93.9 and 93.10, and they were written. The original one was written to provide guidance to the regional councils, and the intention was that the regional councils would adopt it as their process. And we don't have anything that goes back that far to indicate whether the regional councils have or have not. But in 0606, when we finally finished it, we did send letters out saying this is, the SEMSCO, the Systems Committee at that time approved it, and the SEMSCO approved it, and that was the process. And we got very little feedback from the regional councils. And I agree wholeheartedly that anything we can do to assist the regional councils from a process perspective is certainly constructive. However, those policy statements have been out now forever, and the appeals on process are basically because either the regional councils don't have internal policies that address the process, or they're not following the current one, which is 0606. So in any case, it's not a good situation. So in chatting at the executive committee meeting years ago now, mostly Bob DeLoggy wrote or put together on behalf of the SEMSCO a guidance document really to help do QA. It was really a manual for QA, and it was extremely well received, and it was just that. It was a guidance document. And I don't have an objection to the SEMSCO putting together some sort of document that a REMSCO can use as a guideline to help them do the process. But from our perspective in the health department, our policy statement is not, we can't require under the law certain elements to be followed. And so our policy statement can certainly refer to guidance, and our staff are experts in the CON process. They have a lot of exposure to it, and continue to consult and will be helpful in as much as they can. But I was really blunt this morning. I'll be slightly less blunt now. I think that the regional councils, for their part, have to step it up a notch, or two or three. Under the law, they make determinations of need. What's happening to my office is that the regional council will get an application, and the CON committee will meet, and they'll go through all the paper, and they will make the decision that the application is complete, and then they'll send it to us, and then Dan's folks take a look at it and find that there are huge chunks of it that are frankly missing, and yet the regional council committee has established it to be a complete application. And so now from a process perspective, we're chasing each other's tails around. And for that, I think that all of the regional councils really need to have a better picture on this. This was a problem in 06, which is why that checklist exists. We're happy to work with you and update the checklist if you think it'll be useful. But we've had regional councils make determination of need on essentially incomplete applications, and I can hear the guys, no, don't vote, or they voted and they have to substantially change the way that the vote was taken, and those are situations that are being appealed. And honestly, if a regional council determination is to be appealed, it should be appealed on the substance of the application and need. Is need established in that particular geography, not whether you followed 0606. So again, I'm not suggesting that we're throwing the regional councils up into the sky and seeing how many pieces they land in, God no. But what I am saying is that I think the regional councils need to be more vigilant. They need to understand the process, and I think if done correctly, it is not going to eliminate appeals, not in this environment. But procedural appeals may be minimized in as much as possible. So we'll work towards that.
I did ask if there was such a thing as a SEMSCO advisory, and the answer was no. So it would probably be a document coming out of the Bureau that we help them write, as far as the assistance document, not the policy. And it came up at the meeting, but regional councils are supposed to have their own policy. And if they don't have one, then they default to 0606. And we've all seen the ALJ decisions that cite 0606 because the regional council didn't have a separate policy on how to handle their CON issues. So anyways, that's the plan going forward. Is I'll communicate with Dr. Langston when he returns and fill him in on the meeting. Ray's already sent me a resurrected document of the issues in Article 30 that are not addressed in regulation, and we'll review those. And we will go forward from there. That's my report, Mr. Chair.
Thank you very much. Next up is the Legislative Committee. Wes?
Good afternoon. The Legislative Committee met yesterday afternoon. Secretary has the attendance list. No motions coming forward. The session just began. I'm sure there's going to be changing in upcoming months. We did have a conversation about the EpiPen legislation that Lee already talked about, so we don't have to go through that again. Other bills to discuss was Senate Bill 0827, which creates a crimes against EMS providers as a hate crime. Sort of ups the ante as far as what the prosecutors can have to use for criminal offenses. Senate Bill 07658 allows colleges to start their EMS service. They don't currently have one, and it's a $60,000 grant that's available for funding. Again, that's just a one-house bill right now, just up for discussion. So keep an eye on that one. Senate Bill 7275 classifies EMS as an essential service for the purpose of state aid. Again, this is from the senator in Watertown, New York. Again, it's a good start. It puts EMS maybe as part of the conversation in the legislature. One of those kinds of issues. Steve Kroll mentioned that there's new legislation on the federal level. I'll have Steve and Dr. Daly discuss
Yeah, we got Dr. Daly just snuck out, so I'll get it.
Okay. Well,
the House of Representatives passed the bill 404-0 yesterday on Monday, and that doesn't happen very often. That would deal with a controlled substance issue, drugs issue. The DEA had recently started working on a new policy statement relative to the use of paramedics being able to give medications, or EMTs being able to give medications. And they had indicated that they would allow such to happen as long as there was a direct medical control contact between the paramedic and the physician. In other words, they were going to basically take the entire system of protocols that our EMS system is built on and disassemble it. And I guess the DEA was able to do that. So the House of Representatives has passed legislation that will make clear that physicians can use protocols to allow paramedics to administer medications, and it's going to go to the Senate, and I imagine it will pass there as well. This has been a priority of the National Association of EMS Physicians, and so hopefully that'll get done in the next couple months before the DEA finishes what they were trying to do.
Steve, thank you. That concludes the report of the Legislative Committee.
Okay. Mark, safety.
Good afternoon, and thank you, Mr. Chairman. The Safety Committee met yesterday afternoon. We have 3 items on our agenda, continuing with the review of section, our Part 800's .22 regarding ambulance manufacturer standards. There's been quite a bit of discussion from the discussion that we had in May of 2016 regarding that statute. And after our discussion yesterday, we're going to have some more over the next several months. But my plan and our plan as a committee is to have that before the SEMSCO in the May meeting for final decision. Most of these discussions revolve around the disparate standards that are out there currently, whether it is the triple K 1822 version 9 versus the CAS standard, the Committee on Accreditation of Ambulance Services, ground vehicle standard, and also the standard that is promulgated by the NFPA, thank you, the National Fire Protection Association 1917 standard. So those three standards are out there, and there's been discussion as to whether we need to actually have a New York State standard at all. So we're going to be discussing that further in the coming months. Following that is the review of DOH policy, BEMSAT policy 0013, which deals with emergency vehicle operation. We are in review of that, as there are a number of parts of that policy that reference New York State vehicle and traffic law, as well as some best practices, and it is in desperate need of review and updating. So we'll be looking at that over the next several months as well. And I have a team of members that are going to be taking apples-to-apples look between the vehicle and traffic law, current training programs such as CEVO and EVOC, and comparing that with 0013. So we'll have more on that in May as well. And then finally, food for discussion within the committee, and it's part of what I feel is our mandate, as well as reviewing provider safety and looking at some of the issues with violence toward EMS providers. There was a study provided to me by Tom Fortune from the department regarding attacks on EMS providers in the first quarter of 2016, and there were 12 reported through this event process. And what I'm hoping to do is to engender some discussion within the committee about means by which we can help providers mitigate some of these violence issues, whether it's through scene safety awareness training, formal defensive tactics training, and whatnot. There are a number of different programs being offered, both within the state and nationally, that address these issues. And the unfortunate part is there are so many different programs, and there's really no sense of solidarity within them. So we're going to look at that over the next few months as well, and come up with some recommendations and some discussion points within the committee. And that's the end of my report.
Any questions for safety? Okay. I think, Mike, you're going to give the EMSC report. Is that right?
Actually, I think Bob Delagi pretty much covered it, but
okay.
EMSC is going to take a look at the BLS protocols with a particular focus on application to children. And EMSC would also just like to remind everyone to look at the pediatric equipment requirements for your ambulance, as it is part of the EMSC grant to ensure that all ambulances in New York State have the proper equipment for treating kids.
Okay, thanks. And Mike has been the SEMSCO representative to the EMS for Children's Committee. He'll be stepping down from that role as well. So we will be looking for somebody to fill that role. The committee meets here in Albany a couple times a year. And so Mike's been journeying all the way from Long Island to do it. But if there's someone that wants to journey far for that committee, or just someone that lives locally that'd be interested in serving on the EMS committee, just please see Donna, and we can look at who our candidates for that committee are. Okay, I think we don't have a state trauma committee update because they meet next week, but I think you already talked about the trauma verification in your report, right? So we don't need to do that now. So I guess we have to look at if we've got anything under old business. Okay. Do we have anything under new business? I know there was a potential item. I don't know if that's been worked out, or so. Do we have any new business?
It's a non-item.
It is a non-item. Okay, so that's been worked out. Okay, so I guess what we're going to do is after a few announcements, we'll adjourn the meeting. But we're going to stay on the webcast so we can talk about the work of on the conference calls. And so the last time that we had something like this after the meeting adjourned, 2/3 of the table ran to the door, and we had a really good guest speaker talking about DSRIP. I understand if you got to get somewhere, you got to go, but the idea of bringing educational conversations here, even though it may not be part of the statutory responsibilities of SEMSCO, is for everybody's benefit. So, stick around if you can, okay? Yeah. Yeah, we're going to take a 5-minute break. That's a good idea, because we've been going a while. Okay, so May 9th is our next meeting. EMS Memorial, May 23rd. Vital Signs in Rochester, and there is a flyer out there, and I'm sure you'll get all the that in the mail. So we'll be need a motion for adjournment. Second? All in favor? Okay, and we'll return in 5 minutes to have the other discussion. Okay, we're ready to go. All right, well, welcome back to our show. We'll talk a little bit about the conference calls. One of the things that the conference calls were designed to do is get people talking with each other. So even if there's no concrete policy that comes out of this, a lot of folks have started talking to each other. A lot of folks shared some good ideas. As we exit this conversation, one of the questions is, so what do we do next? Do we keep doing more of this? My hope is that by stimulating all of us to start talking with each other, and some people that I didn't know that had some really good ideas reached out to me over email afterwards, or started sending documents to each other, things that other people are now using. So, for example, there's an agency, and I don't remember the name offhand, but we all know that has done a really good patient satisfaction survey. And so other people could use the patient satisfaction survey. There are other people who have done assessments of agency strengths and weaknesses, and they've designed tools. There are all sorts of things we can use out there. So one of the things I've learned from this is, as much as there's a lot of things that aren't going so well for us, in different corners of the state, there are people that have figured out different pieces of it, and when they're willing to share that together, it can put together a lot of really good stuff. So Donna, if you move forward on the slides, the first slide here, I'm not going to read it. It is simply the summary statement we used to frame this project. We're facing challenges. The pathway is complicated. The citizens of New York State are relatively unaware of the struggle that we face. And so they think an ambulance is coming. And we're at a point now where we're not sure that in every town, every time, that ambulance is coming in a timely fashion. And we ought to be doing something about that. So, Donna, if you'll take us forward. These are the topics that we discussed on the calls. We started out with only a couple, and new topics got added as we went along. I'm not going to read through them. We'll go through them. The last one kind of appeared on the horizon, EMS leadership and agency consolidation, through the conversations when we realized people were starting to talk about this 800-pound gorilla in the room. And so I tried something that, I was told would be life-threatening. I got up in front of the gorilla. I'm going to have to save it, look for it, because I saved this note because I'm going to have to go to Vital Signs again this year, but I prevailed on Lee to let me sort of pontificate for a minute before we presented the awards. And I told everybody in the audience, yeah, I got to think about whether or not your agency is going to be here in 5 years and whether or not you got to think about merging with somebody else or doing something differently. I didn't get booed. On the other hand, I think people haven't thought about that. And now I happen to be the product of my agency is the product of a merger, and we're in the middle of trying to do another merger. So we're doing these things, but to a lot of people, it's not, they haven't thought about it. So we'll talk more about that. All right, so next slide. This is just some clear demographics that have come up through all the conversations when we move forward on the underlying for us. We have a population that is shifting in New York State that essentially is going to mean more business, okay? We all know what that is. These are the people that are becoming more and more of our medical calls. We have public health challenges in New York State. There's just one of them up there. And essentially, those public health challenges we're at the front door of them, right? Because when those things happen, when we have people with hypertension or hyperlipidemia or whatever it is that's caused by lifestyle changes, unless they drop when they're in the hospital, when they drop, we're going to be there to deal with it. So. We're in the middle of a really big health system restructuring. That's only one part of it. There are communities where the hospital that was there isn't there anymore. There are also, interestingly, other things there, other than the hospital now, that unfortunately we're not yet able to access in the same way. And tremendous lack of public awareness of EMS. If you go out in the street and ask people whether or not, volunteer EMS, paid EMS, most people don't know. So next slide. The first thing we took on was the business model and sustainability, financial sustainability of EMS. No surprises here. Medicaid doesn't pay the cost of providing the service. It's especially severe if you're a high Medicaid agency, and we have a lot of agencies that are in communities where they are overwhelmingly funded by Medicaid. DOH is doing a study of the cost of Medicaid transportation. We all know what's going on in the budget world. Are they going to raise our Medicaid rates? Then not without a fight, right? Medicare rates aren't exactly generous, but they're more. And so if you get paid your Medicare rate, can you make ends meet on it? And then, of course, our non-governmental payers is where we counted on over the years, but they're taking a second look now, right? They don't just pay you the fee-for-service rate anymore. They're more likely to try and pay you the Medicare rate. One of the things that I see Allison had stepped out, but one of the things we talked about in the hospital field over the years. Okay. So both Allison and Sarah here, one of the things we've talked about in the hospital field is you got to learn to get by on your Medicare rate. Basically, if you can get by on your Medicare rate, you can do okay, because those private pay rates are going to go down, right? Now, unfortunately, different people are in different communities with different payer mixes, and unlike hospitals, we don't get an add-on for teaching and disproportionate share and things like that. But so that's the reality. Our payer mixes are shifting, and there's some unpredictability. We don't know if they're going to shift again, right? A lot of people have come on to Medicaid. A lot of people have come on to the New York State Basic Health Plan. Your frontline EMTs don't know who was uninsured last year that's insured this year, but a lot of people are. And Obamacare signups are at record highs because they're promoting the heck out of it. No idea what Congress is going to do, but no idea what the state will do in response to what Congress will do. But reality is our payer mix is going to shift again. And then growth in high deductible products is huge. And essentially in a lot of the high deductible products today, it's the same as self-pay, because the high deductible is so high that your ambulance bill isn't going to get paid. It's cash, basically, if you're going to get cash. Interestingly, some ambulance services have learned if you delay sending the bill and the hospital bill gets sent first, the hospital takes the hit on the deductible, you might get paid. But then you got to hold your bill. And one of the things that came very clear to all of us on the call, we need increased business skills to deal with finances in the EMS environment. It's a volunteer thing, it's a paid agency thing, because it's not just the business office of old, it's not just billing, okay? We have to understand, because we now have been dealing with insurance denials, understanding denial management. Hospitals have whole departments that deal with this stuff, and they're basically trying to outsmart the insurance companies. If you're a volunteer agency and it's a volunteer that does your billing, or you don't have a whole department, and if you're a commercial or a paid provider or a government provider, you may not have, your folks may not be going to seminars on a regular basis on, keeping ahead of the insurance company, so to speak. So we really need that business acumen. So next slide, please. We all know that wages are an issue for us, and it's pretty easy. Wage increases and expense pressure are not supported by our revenue increases, right? At most, our revenue is stagnant unless you can grow. If you can grow your volume, you might be able to do okay, but volume growth only happens through, specific things, taking over. If someone else goes out of business, you get their territory, your volume grows. But essentially, our low wage levels impact recruitment and retention, but our expense pressure is going to go up faster than our revenue, and that's a problem. We don't even know what to think about capitation and global budget models. In other words, there may be a time where people want to pay us differently, not by the ambulance call, but pay us a set fee to take care of an entire population. How many people know how to do that? We don't yet, but we may be in that environment in a couple of years. And it's not all about the money we collect through billing. It's also the money we collect through taxes. Tax cap pressure on local jurisdictions is strangling local jurisdictions. The governor took another whack at them in the State of the State this morning in Syracuse. He basically, turned it all around on them. And even though the majority of expenditures for local jurisdictions actually is government mandates, there's huge pressure on the local jurisdictions. So I'm getting a 0% update in my tax subsidy because the town supervisor came to me and said, look, you know, my tax cap this year is like less than 1%, and I got to do this, I got to do that. Can you live with no increase? So it pits me against the police department, then against the water department, against the whoever, because we all got to come in under that tax cap. And so when an EMS agency that has been struggling and struggling and struggling and shows up at the town's door or the county's door and says, yeah, we're going to have to hire some EMTs, and I need $500,000 next year. I mean, the head explodes, right? They can't do that. So we're depleting our reserve funds. Our capital cycle is lengthening. Larger capital needs are being delayed or are really beyond reach. If you didn't build your new building, you may not be building your new building. I've been talking to some of the guys at the ambulance manufacturers. Those $160,000, $170,000 big box ambulances they're not going to be making them anymore because there's nobody that's going to be buying them. Because, you know, if you can't do it for 2/3 of that price, there's no buyers out there that can, in whatever your capital cycle is, amass that much money. So the reality is our capital cycle is changing, and for some agencies, the reality is they're just able to basically keep it going, and they don't have a real capital cycle plan necessarily. And the public has no idea how EMS is funded and doesn't understand the funding, and so that makes it more complicated, right? Because nobody wants to pay more taxes, right? Nobody wants to pay higher health insurance premiums, but essentially that combination of stuff is funding us. And as I said, municipalities they're not real happy when we show up at the door and say, hey, you know, we need a hand. So next slide, please. So bottom line, we're not an essential service in New York State. That's an issue. There's legislation about that. If we're not an essential service, that's a huge problem. I think changing that's going to be a huge lift. But until we get there, we also remember that our finances are driven by forces we don't control. Socioeconomic forces drive high Medicaid volume. Okay, if you're in business in a community that's got socioeconomic issues, have a high Medicaid share. You know, the ACA, I talked about this, the ACA has increased our Medicaid volume, lowering self-pay. What happens if it flips around? Or what happens if someone brought up, will high utilization patients end up with high deductible insurance? Generally, people that are high utilizers they will choose to get health insurance over food because they know they need that health insurance, and they'll try and they'll buy that platinum or gold product instead of the silver or bronze. But what happens is, what if they really can't afford it, and it becomes if our high utilizers end up in the lowest tiers, we have a challenge. On the other hand, if they end up in the highest tiers, the price of the highest tiers will keep going up and it gets too expensive. So we're not experts in health insurance, but we're going to be victims of health insurance. One of the things brought up is, well, if we start really cranking down on billing, whether that means collect copays and deductibles, and we never billed before and we're going to start billing, will our donations dry up? That's a good question for voluntary agencies that do things. And the perennial question that we will probably never solve here at SEMSCO is the issue between fire-based volunteer EMS being able to bill and the ALS First Response Services being able to bill. Because under current law, you can't have both. If the fire agency starts billing, the ALS First Response Service has to stop billing. And so it's not something we've been able to work out at SEMSCO, and so the fire agencies want to be able to bill. The ALS First Response agencies want to still be able to respond in those communities. Until there's a change in federal law, it's an intractable problem for us. And, I don't have a solution. All right. So that's the financial and business model. And I don't know if we want to just stop every couple of minutes, throw in your comments, ideas. So that's what we talked about on the business and financial sustainability model. So comments, thoughts, indictments, things we missed. I'm sure we missed a lot. This is just what we talked about in an hour. All right. Okay, keep rolling. So EMS workforce and recruitment and retention. Aging EMS providers, both volunteer and paid. The average age is over 40. We had some statistics that you shared with us on the age of EMTs. The average age of an EMT is going up. The number of EMT students is relatively stable, it sounds like, but we need it to grow. The next generation of EMTs has a different work ethic. The generation of EMTs that gets their card and wants to ride 24 to 48 hours a week on the volunteer ambulance has sort of gone away. And the generation of paid EMTs that really think working 96 hours a week is fun is also sort of starting to go away. So the concept of volunteerism has changed. We had some statistics on volunteerism, and didn't we rank like 46th out of 50 states in volunteerism?
We're up to 49.
We're up to 49. In other words, that's on the bottom. In other words, in Utah, people volunteer. A large share of the population gets involved in volunteerism. In New York, one of the lowest shares of volunteerism. So we got not enough providers. That's why we're going to try and do this data collection, this survey we talked about. So next slide. So let's see here. So we've got the pressure of competitive employers. Look, similar pay can be earned in less challenging careers, right? Walmart's national average wage right now, their target is $13.70-something an hour. If you're paying your paid EMTs $12 an hour, and Walmart's paying $14, I'm not saying your EMTs are going to go work at Walmart, but if they have a crappy day and they're not having that much fun, boy, there is a lot less responsibility working a cash register than there is working as an EMT. I'm not saying that our workforce is doing that now, but I gotta bet that I'm an EMS provider here in the Capital District. They just opened up. They just took applications for 1,400 jobs at the casino in Schenectady. I'll bet you a whole bunch of my EMTs are hoping that they're going to be card dealers in March or April when it opens, because they're probably getting paid $16, $17 an hour to, and they don't, hopefully they're going to get thrown up on less. And so it's funny because when jobs were tight, things were good for us, right? In 2008, when firms were shedding employees and there was a recession, if you had an EMT card and you got laid off, I got an instant next career. But now when jobs are not tight, people have more choices. It hurts us on the workforce side. So I think we're all troubled that providers are working multiple jobs to earn a living. Providers are just exhausted. Dr. Daly and I have talked about, because Dr. Daly was my medical director for a bunch of years at my agency, and we talked about whether we were going to put a rule in place that you couldn't work after working a certain number of hours, you couldn't work any more hours. What we ran into all sorts of complications, but we've never been comfortable that somebody comes from a 24-hour shift at another agency to a 12-hour shift at our place, and they hoped, and if everything works out and they got 8 hours of sleep on their 24, that's great. But if they're showing up at my agency for their 12-hour day shift after they busted their butts all night long, that is, you do not want to be that patient when you're having the major event. So how are we going to deal with that? One of the problems with dealing with it is we don't know where they came from, right? They're on our schedule, 12 on, 72 off, 12 on, but we don't know that they haven't worked a whole bunch right between there. Yeah, Don.
Yeah, just a note on the previous slide with the volunteerism. One of the problems, obviously, is the economy, where people are working several jobs in order to make ends meet. But something that I think a lot of people aren't aware of, especially for these kids, is that I understand FASNY has a scholarship program for these kids that if they meet the requirements of their volunteer agency, right, and participate with volunteering their time, they actually have scholarship programs where they will pay in full their community college.
Oh, cool.
Thing. So just something to note. You should
That's
put
good
that
to
out
know.
there.
Thanks, Don. Appreciate that. Yeah. Right. Okay. Cool. Well, thank you. All right. Yeah.
Another thing, and it may be a little farther than you used to have, sorry, but we got ALS providers, and in the discussion today, it's been discussed for a couple of years about what's going to happen with CC.
Right.
You go get more classes. When you're in an area where you don't have a paramedic program, I've got 2 people going to paramedic class right now.
Yeah.
One day of paramedic class is 8 hours.
Right.
It's a 2-hour drive, 4 hours of
Yeah.
class, 2 hours home.
That's definitely, we've heard a lot about that.
And there goes their job.
Yeah.
They're trying to work that around in their family and So another job opportunity comes along, and you say, I'm making 15 here, I'll get 22 when I get the paramedic, but I can go over here and I don't have to learn. And they're jumping.
Right, yeah.
They're jumping hard. Because
Right.
the jobs now, I may not be there later when they make this change. And that's a real factor for us.
That's good, thank you. All right, and there's a little more on the training when we get a little further down, because I know that that's something we've learned a lot about by talking with, Patty and the folks from Essex County and the struggle they were having. Another thing about this, people working multiple jobs, you got to have your loyalty somewhere, right? So if you're working for, I happen to be at an agency where most of our folks they're not ours, right? They're full-time somewhere else and they're part-timers with us. When they don't want to work, when they're it's snowing and they're mandated at their place, we're sucking wind, right? Because they're not coming in. And so what do we all have to do? We have to all try and get everyone as full-timers instead of part-timers, that we get into a sort of a competition for employees. Definitely the lack of an EMS career path in many EMS systems is real. I mean, there are notable exceptions. There are places around the state that have created EMS career paths, but there are many that are either too small to or have not succeeded. EMS is becoming a stepping stone to other careers. There weren't, I think there are a lot more options in healthcare for people today that pay a lot more, that if someone who would have worked as an EMT and stayed there, or a paramedic and stayed there, is suddenly finding themselves in all sorts of high-tech EMS, high-tech healthcare jobs that they go on, and they earn $60,000, $70,000, $80,000 a year when, this was something that was brought up. More than 80% of our calls are BLS in New York State. Is it okay for some communities to convert from ALS to BLS to become more viable? And you have your paramedic service that supports you, but you don't have to. Not everyone has to be ALS. And I'm from an agency that was ALS for many, many years and got sort of, it didn't make any sense anymore, and we went down to at the time the EMTI level. That was a really hard choice for us to make. We were helped, but the reality was that not one person in our community is receiving worse EMS care, and the drugs aren't sitting in those drug boxes rotting and having to be thrown away because we're not actually covering the paramedic portion of the call anymore. And so, that's a reality. So on the next slide, we are all competing for the same pool of responders. That results in salary inflation. That salary inflation is good in one respect and bad in another, right? If we're broke and we can't afford to keep bidding up salaries, it's tough. On the other hand, it's good for the EMS provider if we're starting to pay them more over time. One of the things that we heard about is small ambulance services hiring paid staff that they really can't afford to get them by, and they basically run themselves into the ground, and then when they run out of cash, they shut down. And that's not good planning for the future, because it happened right in the town next to me. They used every penny they had. They went 6 more months, and then, all the air was out of the tires. And a reality, communities want EMS service, but frankly, nobody wants to pay for it because we're not a mandated service, right? How many police departments have to beg, grovel, and steal to get by? For the most part, they're in the tax base. They're expected. Every once in a while you see, a police department getting told by the city or town to, I think Troy went through something this year, but, it only took about a couple days after they proposed cutting a unit from the Troy Police Department for them to put it back in, right? So we have to grapple with that. And then, the last one on there, the Bureau of EMS's challenge is, as Patty went through in her budget presentation, our Bureau can't even fulfill the functions it needs to because of their budget. And, I think it's a reality that, I think you've put more work into at least publicly, you've talked more about the budget than most years the budget's been talked about here. That work is, I hope everybody here takes it, and, some of you that are sitting around this table wear other hats. Take that budget, and there's some really key senators and assembly members who ought to know. We're not talking about an $160 billion budget, a heck of a lot of money here, right? You're talking about tiny amounts, but could do huge difference for EMS. So, all right, so on next one up, we got, okay, ideas discussed, not necessarily endorsed. Should EMS providers be licensed? We've been discussing that for a long time. Should we be developing countywide ambulance initiatives? There are several successful models. Greene County has done it. There's some folks in Wayne County who have brought something together. I think there's some folks in Jefferson County that have brought some agencies together in a collaborative way where they're supporting each other. In southern Albany County, we're working on it. Some folks talked about the bunk-in programs where they bunk in college students and basically you get room and board for answering calls. There's can EMS providers pool together to improve benefits? And then the question is, do we need to decrease the hours worked? So I put up there not necessarily endorsed because I don't know that everyone likes everything on the list, but those are the things people shared with us. All right, next, so that's the EMS. Any other comments on workforce? Because we'll exit out of workforce into the next one. Okay, integration of EMS into the healthcare system, patient-centered. This is the one that when I talked earlier about, I think there's a lot more that we haven't done yet. So Donna, can you push us to the next slide? Or there we go. Hospitals don't yet act necessarily like we're an important piece of their stay. And in some cases it's starting to happen, but in other cases there's still that we're still isolated outside of them. I think the tenor of the call is there's an opportunity for EMS to work with healthcare. One example is the transitions of care. There's some really good evidence out there that a lot of healthcare errors happen in transitions of care when one caregiver hands the patient off to another caregiver. When the nurse on the day shift hands the patient off to the night shift, right? A lot of work is going on in hospitals to prevent that from bad things happening there. On the other hand, sometimes our patient reports are non-existent. Sometimes it's because the EMS provider is a little rushed. Sometimes it's because the hospital staff is a little rushed. That transition of care can be an important moment for us to give them credible information. We're not well integrated with niche providers. So how many of us really like going on calls for people with behavioral health problems? Because we don't have the special training sometimes, nor do we have the specialty ability to hand them off to people that have that specialty training. More often than not, we're handing them off to an emergency department that's got the same problem as we are, which is, well, my goodness, we don't really know how to handle this behavioral health situation. We got to figure it out. Same thing with end-of-life care and hospice. Same thing with disability awareness and special needs populations. So there's certainly an opportunity in there. And that brought us to the question on the call, what can EMS bring to the table with healthcare? So if we can hit the next slide, we talked a little bit about what EMS could bring to the table. Many of us are moving to electronic medical records. Now we have to get our electronic medical record to talk to the hospital electronic medical record. Number one, can we get our information in? Because nothing makes me crazier than when I've done all the work to gather all this information and then the hospital absolutely starts over from zero. And maybe it's because they think I'm not very good at collecting the information, but nevertheless, it's getting done twice. So can we get our information into their record? Can we pull record out? Right? You're showing up at the house of somebody who is a frequent ambulance caller, and your regional health information organization has information on this person that we can pull back out and look at that helps us with our assessment. And can we use integration of the information for quality and outcomes improvement? It's starting to happen here. I get emails now from the two major hospitals here with reports on STEMIs, how it went. You know, what we did right, you know, we haven't gotten one that said what we did wrong, but I imagine someday we will. And so they're reaching back through EMS charts to us to say, hey, this is what happened. That's kind of cool. There was a lot of talk, I think, especially in the rural areas, that EMS expanding the safety net role as home care is being reduced. Home care services are being cut budget-wise. And so somebody who had a home health care aide for maybe 16 hours a day suddenly only has them for 8 hours a day. And so now that's putting more pressure on us. A challenge was definitely brought up of the lack of behavioral health capacity, and just that people that should be using EMS that don't, and those that shouldn't be using it are filling up our capacity. I don't think that's new. So a real good example several agencies brought up is the work they're doing on fall prevention. Some doing it in collaboration with hospitals, some doing it as part of district, some just doing it on their own when they figure it out. If you can help people not fall, you're eliminating ambulance calls. All right, so next slide up. A lot of frustration of our lack of ability to move forward community paramedicine. You know, we've done our part, right? We've come up with a model. It's being, right now, it's, you know, we've got our approach. The nursing homes and home care agencies have their approach, which is to, well, not let us do our approach. And if we can get past those guys, then there's the nurses union waiting to whack us. It's a legislative priority, but it's a really tall hill to climb, yet community paramedicine is prospering all around the country. I don't know how to break that. The home care folks offered us a deal. I don't know where we are on that. But you know, the new legislative session is starting, so I guess we got to rev it up and try again. There was some talk about potential for EMS Compass, which is the national development of measures in EMS. What I learned from the call is we're not all that. There are definitely some New Yorkers involved in the EMS Compass, but for the most part, most of us don't really know much about what it is. And so I've been doing some reading about it, and you know, I don't know statistically about the validity of the work they're doing, but there's an awful lot of people with doctor in their name that are part of that initiative, and they got an awful lot of information out there that looks like they're doing some good work in outcomes, in figuring out outcomes. And then there was discussion of customer satisfaction surveys, and I have the name of the person in my files that has got one, a great one that I know I'm going to try and use. All right, next slide. This is related to quality, value, and outcomes. This is another one where it was like pulling teeth to get people to talk. And I think that we think that development of the measurement is early. We think that there's a real challenge in differentiating data that measures value and outcomes versus that doesn't. In other words, you can be measuring a whole bunch of quality stuff that doesn't really matter. And I read an example from Boston EMS study. Response times in Boston are not in any way statistically linked to patient outcomes. So the faster you get there doesn't change patient outcomes in that study. But what does change patient outcomes is the training level of the provider. So the answer there is, do you want to invest your money in the better trained providers, or do you want to invest your money in trying to figure out how to shave a half minute off your response time? But that's the question that they're grappling with in Boston. And something that we were all unprepared to talk about is how do we prepare for value-based systems evolving in the health insurance and hospital realm? When will we start seeing value-based metrics in our contracts? In other words, when is somebody going to either Medicare demand or a hospital tell you that you have to produce certain metrics of success that are defined for you in order to get paid, right? So, you know, I don't know what they would be in EMS, but, you know, it could be that if you're not, you know, if you have a contract with a continuing care provider, a nursing home, you know, we take 5% off if you're not there in 10 minutes. Would be an example. Not a good example, not a valid example, but one of the things about using these value-based outcomes is people default to the easy stuff. They can't figure out how to if you can't figure out how to really measure outcomes, you have to measure the simple stuff. So I don't know if anyone has stopped getting paid for medical errors, but I think insurance companies will start auditing our charts, and if they see a medical error, they'll stop, they won't pay. And I think that's coming down our road, you know. So, you know, so next slide. Then we got into the discussion about what's happening locally. Some of our bigger EMS systems have really sophisticated quality metrics and quality work going on. Some of them have none. And it was quite clear, and this is among the smaller agencies, a lack of direction, a lack of bandwidth, and limited interest. We have a quality committee and nobody comes. And, you know, we got 1,000 other things we got to do to make it run, so we just don't do quality stuff. There was a consensus that the regional QI committee meetings are the same. No real leadership agenda in many of them. That has led to a lack of interest. And I think it was pretty clear that we all felt on the call that most people do not yet realize the payment's going to start to be based on performance. I don't know when that's going to happen, but you know, if that's indeed the truth, most providers don't know it. And so we kind of have to start thinking like healthcare providers, was something I brought up on the call, and I'll show you on the next slide. And I've talked about this here before, the IHI triple aim. You know, the triple aim is we can improve the patient experience of care, improve the health of the population, and reduce costs at the same time. And that's the goal that hospitals are shooting for. Now, there's now something called the quadruple aim, which is adding into it improving the care and experience of the provider. Hospitals have recognized all the things they were doing to try and do the top three were kicking the crap out of their staff. And so they put on their number 4, which is basically take care of ourselves. All right, next slide. So quality, value, and outcomes. I think there was a lot of talk about STEMI and stroke initiatives being someplace we've done some success. Somebody asked, you know, one of the things about quality, value, outcomes is how many agencies know what percentage of calls they're turning over, and is there an obligation for the public to be aware of that? And we didn't answer the question, but it was asked. And then just a little about EMS Compass. So I think that takes us through the quality, value, outcomes. This last slide on it that's about to come up, I read this somewhere and thought it was worth putting in here. It's about the right metrics, the right analysis, and then using it to change stuff. Do something with it. So that brings together the healthcare piece of this with the any thoughts, comments, additions, ideas?
Well, I just thought I'd add in, so first off, data, and everybody's system is different, but you can't fix something you can't measure.
Right.
And our data is terrible. We have partially paper, we have 6 or 7 different electronic charting units, every hospital's using a different electronic charting. Getting data is like pulling teeth. You put surveys out there and they don't get answered. We all know this.
Right.
So I think that, you know, answers, and I see heads shake around the room, so probably everybody else experienced the same. One of the things on the quality and education initiative that I have just started and haven't really got out there yet, but CQI, or continuous quality improvement, always seems to be perceived as punitive in many, many places. So the actual last 3 concerns that have come to the region have been reviewed by the regional medical director and myself, and we are going back to the providers, and we are requiring them to do educational PowerPoints. And quite frankly, our first one, we got a great educational PowerPoint back. So now once I get through the technological challenges, to get that posted, and we'll be able to put a quiz up and offer CME credit. So we're hoping that that kind of helps a little bit, because the issue was not something that, it was one of those odd events. So people need to maybe use a little more caution sometimes when using certain pieces of equipment.
Cool.
So the patient's kind of.
Metrics, analysis, do something with it, right? Yeah.
But it's hard to get that data. I mean, it's just you don't have the.
Right. Okay.
But you're at least getting that education back out.
Right.
We hope.
So other thoughts, ideas? Up behind me. Yep.
Also, in terms of research and publicly available information, it is difficult to obtain that in New York, where even for something like looking at how many providers do we have, are they currently active? So if you want to access the providers and survey the providers from a research standpoint, it's very difficult to access what we have currently, not even moving to outcomes, because if we have an input problem, we're not going to have an
I'm supposed to track them and I can't.
Right.
But it's also a challenge there too.
Right. Okay. Cool. All right. So moving forward, I'm going to skip the slide on DSRIP because we spent a whole lot of time at the last meeting talking about DSRIP, right? But you know what it says. It says that we have partners out there that we ought to be collaborating with because they have to lower admissions, they have to lower readmissions, and they have to stop inappropriate ER use. And we're the ones that bring people for the admissions and the inappropriate ER use and the readmissions. A lot of talk about rural EMS. We had a special call on rural EMS. Agencies shutting down at a rapid pace. Many small agencies, there could be a very large geographic area with several small agencies, and they're all unsustainable. We talked about our mergers being the answer. There may not be in those places enough call volume for a paid ambulance service to come in if the volunteers go. Paid ambulance services have to have a critical mass of calls in order to pay for it, or the taxpayer's got to put up a whole bunch of money, and then you get into that tax cap thing. So, you know, the volunteer squad goes away, you call up the local commercial, and you say, I want an ambulance, and they say, that'll be $500,000, payable in equal installments over 12 months. And you go, I don't have $500,000, and they go, well, look, call 911, call us up, and, you know, we're 20 miles away. If we have an ambulance available, we'll send it. And, no, I want it here. Okay, that's $500,000. So one of the questions that was asked is, should we have a equivalent of the Critical Access Hospital Program for EMS? Critical Access Hospital is a program that says this hospital is necessary, and we will pay it its costs. Their rates are not the same as other hospitals. It's mostly small hospitals in rural communities that get paid on cost-based reimbursement, and basically their deal is look, we're paying you your costs. If you can't figure out how to manage it, that's your problem. Should that be an EMS? You know, again, we're not an essential service. Should there be a program that says, you know, Devil's Gulch Ambulance is the only ambulance for 40 miles in any direction, it has to be there, and so we're going to pay what it costs to have it. Right. Yeah. I mean, some local hospitals would not exist without the Critical Access Hospital Program. Rural agencies talked about their responsibility for facility-to-facility transfers. That's increasing. And so, you know, they're getting the double whammy because it's a really long trip for them. And they're increasing in numbers, which means I got to take the 2 EMTs I have, and they're heading for a trip to Vermont, and they'll be back in 5 hours, right? You know, now what do I do when someone back home has a heart attack? Many of the challenges are intensified in the rural environment. Local government budget pressure, the volunteers aging, declining young population base, economic realities impacting volunteerism, non-emergent use of EMS, frankly, small town pride. I've met EMS agencies that can't talk to each other because the high school football teams are rivals. You know, I mean, you know, there's a lot of pride out there. Local governments are shocked by the cost of what to happen, and they really, and they don't have the bandwidth to develop solutions. I mean, the local town supervisor is not a full-time government official. The local town supervisor may be, you know, a school teacher or own a business and, you know, spending some time as supervisor, and suddenly he's up against, what do you mean the ambulances aren't going to be coming anymore? I don't know anything about that. And so one of the questions that was brought up is, what about moving to broader county-based systems that have broader response areas? And I know that's, again, we had a couple examples of that. So we can hit the next slide. So one of the things that really got hammered home on the call, rural solutions are years in the making, but we keep the problem in the shadows until there's only a little bit of time left. So if it's going to take 3 to 5 years to figure out how to straighten up or get a rural EMS system that works, but we hide for 3 to 5 years and tell everybody everything is okay, then when it blows up, you know, it's not real good. One question that was brought up is, should hospitals be tasked with responsibility for rural EMS? Because they got talent, they got they're big businesses. I'm sure they're not going to be excited that this isn't my slide, but you know, if the hospital experience begins when someone calls 911 because how the EMS system works depends on how much the resources they're going to have to use to treat that patient, well, maybe they should have some skin in the game in EMS, right? Maybe they got to get involved. Telemedicine was talked about as a standard of care. Community paramedicine again. two things that came up that were controversial. The ban on subscription fees is a barrier to rural EMS in some communities where folks, were subscribers, and that's been, the Attorney General did away with that. I think the one that's most controversial is, I'm sorry? I might have, I don't know. Oh, no, actually, I don't think he got locked up, but he did get in trouble. No attorney generals have gone to jail yet. They get arrested after. Right. And then there's the increasing demand, very controversial, the increasing demands of certification, the disincentive it provides to becoming EMTs or paramedics, and how you balance that with this, except with the raising the level of care. And, and I think we all know there's been a discussion about doing a slimmed down version of EMT, and some people feel like, I need, look, it's too many hours, you have to make it shorter. But some people say, look, this is the national curriculum, this is the national standard of care, we just got there. That's definitely a controversial topic that people come down on both sides of. So that was the rural conversation. Any rural thoughts, comments? All right, regulatory barriers is next thing we talked about. This first bullet basically says, look, we all know that the legislative framework that put in place the EMS system in New York State is old, and we all know that we're not going to change it anytime soon, despite our best efforts. So saying I'm going to rewrite Article 30, Part 800 is going to get completely redone. It's not in the short-term cards. That's a big barrier for us. Another barrier for us, obviously, the community paramedicine. Then a few more on the next slide that were talked about. The inability to use alternative destinations to take non-emergent calls. Doctor usually sits right here. Doctor from the city. No, other doctor. Dr. Marshall talked about a demonstration. He said that I don't know, or that they were talking about is they looked at the law and they believe you can transport a patient that is non-emergent to an Article 28 hospital-affiliated urgent care. And, just, look, baby steps. So, baby steps.
New York City, he has a district project for hospital-based diagnostic treatment centers as alternative destinations. And so there's money for that in their project.
So, at least someone's talking. I want to tell you, someone's talking about it. So,
we don't have a say in it.
But we are certainly a lot of talk about the inability to shift low acuity patients away from EMS. We'd all love to be able to give people that, had a ingrown toenail a cab voucher to go to their local clinic, right? Not take them to the hospital. Can't do it. A couple folks did bring up that because Medicaid recipients don't pay any copay, they have no skin in the game, and so they ought to have some skin in the game. That's certainly on the table at the federal level right now. But all right. So last topic is leadership themes that came out of this, this is a little sensitive because this is where we criticize ourselves, the leaders, a little bit. The public does not recognize what we do, and they think we're always going to be there, and we're not doing anything to change their minds about that. We are horribly resistant to change in the EMS community, and we dig our heels in. Mergers are not a dirty word, in my opinion, but some people think they are a dirty word. I'm going to speak it as often as I can, just so that it gets cleaned up. But agencies need to know how to assess their strengths and weaknesses to help them make decisions about sustainability, and there's a real desire for an assessment tool. How do we assess ourselves? How do we know we're going to be here in 5 years? How do we know we're sustainable?
Answer the question that the survey Rich sent out months ago, which they didn't.
Okay. There are several models of successful unifications, both agency to agency and area-wide. Jefferson County, Greene County, Wayne County. I don't know if anyone from Wayne is here. I know he was here at the meeting, but the 4 agencies came together. You guys had a pretty successful venture, right?
Yeah, Wayne County.
Right. So there are people that are doing it. So, and one of the things that was talked about on the call, that we have to highlight the people that are doing it, so the people that are scared to do it know somebody else did it, and then that the people that that have done it well, their model can be replicated. So, you know, if it worked in Wayne County, it might work in another county that has agencies in a similar position. I know Jefferson, you've had some things that have gone well, right?
Yeah, well, plus years ago, we had two fire department agencies that came together and formed years ago, South Master. And then just within the last 4 or 5 years, we ended up with Indian River Ambulance that was Antwerp Fire, Philadelphia Fire, and Teresa Fire. And they came together and formed Indian River Ambulance.
Cool.
And by doing so, and as you said, referencing those, those are avenues to form an ambulance agency that provides coverage that can legally bill, that if they want to, they can pay providers, and they don't take away from the Medicare option for those fire-based ambulances that still want to stay doing BLS.
Right.
As you just pointed out, many times all they need is BLS. Because
Right.
one ALS provider does one ALS all year.
Right.
But BLS,
Right.
they can keep
Right.
going, and that
So,
other
right.
entity can come in, provide ALS for them, and
Right.
Medicare pays for that.
So,
Lewis County, he had a unique situation with COVID, our agency, where they actually became a part, their ambulance department became part of our agency. We staff an ambulance sometimes in their building, they provide the staff for the program area. And if they're not available, then we run from the centers.
right. So, Lewis County, I gotta write one down, that down. Okay. Can you send me like a 1-paragraph email about how that works? Cool. So this is not was not a make-work project to come up with more projects necessarily, but the one thing I really do think we have to figure out how to do is tell the stories of these successful things like what's happened in Wayne and what's happened in Jefferson, and share it around the state. And I don't know if that's something that NYSVARA can do, or I don't know that's something that you know, the FASNY can do. But if we can get those stories written down into and use them as case studies to show people, you know, it's not the boogeyman. We have the cultural thing. We have to get over our own damn self-reliance and stubbornness. But when you get past that part, then you're scared crap. You're scared to death that you know, this is hard stuff, and so we have to show it can work. All right, next slide. This is about leadership. Clearly, the founding generation of EMS leaders is aging into retirement, right? EMS came of itself in the 70s, 80s. We're getting up there, all right? There are a few young folks around the table, but not real young, right? Much of our EMS management training is on the job, and we don't have a lot of formal management and leadership training structures for the future. And this applies to both volunteer and paid agencies. Volunteer agencies don't have that next person waiting to spend, you know, the time and energy on it. And paid agencies don't have any, you know, you go to school to be a hospital administrator. You know, you don't go to, you know, there's not a college. Actually, there are some college programs in EMS management, but they're few and far between still. I think there's some in New York City. Is Howard doing something in Cobleskill with this? Or, I mean, there are people talking about it. John Politis has his boot camp, but we got to work on this.
On the transition of leadership, I know from my own experience, transitioning, Dana Jones and I had lots of conversations on how to develop a transition plan for agency, and that worked out pretty good. So you do have changes in leadership, but you need to have a mentorship and a transition period.
Okay. So,
And have a plan.
right. Right. So it's both having the plan, but also having the person. Right. So, so last slide, closing theme for us. The EMS community needs to develop the motivation to engage the broader communities in understanding what EMS is. We have to express our vulnerabilities and our potential. We have to engage others in our solutions, and we need to make sure the broader constituencies see the value in what we have to offer and the risk of not taking a piece of responsibility for our future. In other words, if we're just out there alone, we're going to just continue to sort of wither away. But there's a whole bunch of stakeholders out there that need us to be healthy and successful, and we have to figure out how to engage them and bring them in, because we're not going to do it on our own. So this is what I learned through the 7 or 8 conference calls, summarized in some short slides, or not so short slides. I hope it's valuable for everyone that was here to take it. Look, take it to a board meeting and go through it and chop it up, or take it to a local SEMSCO meeting, or use it for whatever its value can be. If it starts a conversation somewhere else, that's great. If not, the 25 or 30 of us are better informed, and shame on everybody who had to catch the train, right? So
Thanks, Steve.
that's what I got. New board, yep.
But the
Okay.
trouble is, having the ability, look what happened to the program agency.
We need to push as essential
You don't have any funding to bring that other person in.
Yeah, but